we have a lot of prognostic data on CFR that's validated, and we know that patients with low CFR, irrespective of epicardial disease, microvascular, the reason for an abnormal CFR, if your CFR is abnormal, it's very well established that patients will have worse prognosis, worst outcome based on just having low CFR. So that answers the first questions. Why the CFR is down? It doesn't matter. If you are walking down the street and you cannot augment your coronary flow from resting to exercise by at least double, hence the value of 2, or by at least 2.5 times, then you are in trouble. Now, we also know from small studies that if you add IMR into it, or if you add FFR into it, which means if your CFR is low because of epicardial disease and low FFR, or because of high IMR and microvascular disease, that cohort does even worse than a patient with abnormal CFR with normal FFR and normal IMR. So these two values are adding more to the outcomes. One of the areas that IMR is very valuable in predicting bad prognosis is data that Dr. Firan had published many years ago, talking about IMR post-MI, which means you have 100% occluded LAD, you fix that LAD with a stent, you put a good Xience, life is good, established flow, your IMR post-MI is very good predictive parameter to knowing prognosis. And this is common sense. If the more you clog the microvasculature with microthrombi, with anything, you will have bad outcomes and worse recovery. But the value there that they published is 40, an IMR of 40. Because if we included everyone with IMR of 25, almost every single myocardial infarction patient will have a problem with microvasculature, because it's virtue of the diagnosis of the disease. So 40, a value of 40 post-MI, IMR is prognostic and has prognostic value. So that will take us to the CorMicA Trial, which we use it as an essence to write our publication in JACC from the Microvascular Network that came out as a comprehensive review in 2 parts. I urge everyone to take a look at it, understand it, read it, because it covered the whole spectrum of this disease from A to Z, and what most of the experts think about how to approach these conditions. Patients like this with structural CMD, they do benefit from alpha-selective beta blockers, which means you pick a beta blocker that blocks the beta receptors and the alpha receptors, such as carvedilol. Obviously, second line would be calcium channel blockers. Third line would be ronalazine. Fourth line, or in the same line, you have avabradine, L-arginine. You have tricyclic antidepressants, SSRI. There's a long list. If you go to the JACC paper from September, first week of September in 2023, you would definitely see how each endotype or each value you get or each bucket of these microcirculatory conditions and how they should be treated. These patients in my practice, I will do alpha selective beta blockers, and I will give L-arginine just as a supportive.